بسم الله الرحمن الرحيم. الحمد لله الذي رفع السماء بلا عمد وبسط الأرض على ماء جمد وقسم الأرزاق فلم ينس أحد ورفع العناء عن كل جسد، والصلاة والسلام على نبينا الطبيب شفيع الأمة محمد رسول الله وعلى آله وأصحابه ومن والاه، فصلوا على خير البشر. عميد كلية الطب الدكتور همام غانم المحترم، القامات العلمية الكبيرة، أساتذة الأفاضل، الحضور الكريم مع حفظ الألقاب والمسميات، أهلا بكم جميعا أيها الحفل الكريم. يقال في الأشعار أن الحروف تموت حين تقال، لكنها في هذا المقام تحيا إذ فيكم تقال. قد يعجز التعبير أحيانا حين تتناثر الحروف ويرتجف الفؤاد وتتبعثر الأوراق ويجف المداد وتتلاطم الأفكار باحثة عما يليق بالمقام. ضيوفنا الكرام، لكم منا تحية العظماء، تحية بأنسام المودة والمحبة ممزوجة بمزج الخلة والأخوة، فالسلام عليكم ورحمة الله وبركاته. أسعدتم صباحا برعاية الأستاذ الدكتور وحيد محمود الإبراهيمي رئيس جامعة الموصل المحترم، وبإشراف مباشر من الأستاذ الدكتور همام غانم إبراهيم عميد كلية الطب المحترم، يقيم فرع الطب في ورشة العمل بعنوان المستجدات في أمراض القلب والأيض Updates in Cardiac Diseases، وذلك انسجاما مع أهداف التنمية المستدامة في الصحة الجيدة والرفاه وضمان الاستمرار في التعليم الجيد. هدف هذه الورشة إلقاء الضوء على آخر المستجدات لأمراض القلب واضطرابات الأيض وأمراض السمنة. سادتي الأكارم، في كل ميدان من ميادين الحياة يبقى البحث العلمي ومواكبة الجديد هو السبيل الأمثل للنهوض والتقدم، فالعلم لا يقف عند حد بل يتجدد كل يوم، والمعرفة بحر متدفق لا يرتوي منه إلا من جد واجتهد وأحسن الغوص في أعماقه. ومن هنا جاءت فكرة هذه اللقاءات لتكون مساحة رحبة لتبادل الأفكار وفرصة كريمة لشحذ الهمم وتلاقح الأفكار والارتقاء بمهنة الطب إلى أعلى المستويات. إن اجتماعنا اليوم هو رسالة التزام بمواكبة التطور وتأكيد أن أبناء هذا المجال عازمون على خدمة مجتمعهم وتقديم كل ما من شأنه أن يرفع شأن هذا الاختصاص في مدينتنا وفي بلدنا، فالحمد لله على سعة النعم ووفرة الرزق. نجدد الترحيب بكم السيد معاون العميد للشؤون الإدارية المحترم الدكتور كرم تراث، أسعدتنا بحضورك الكريم. توفر هذه الجلسة العمل على درجتين من التعليم الطبي المستمر، وسيكون خلالها جلستين، الأولى بعنوان Updates in Heart Failure، الثانية The Impact of Diabetes on the Skeletal System. في كل جلسة ما يقارب سيتم طرح 3 محاضرات. نترككم الآن مع كلمة للأستاذ الدكتورة أروى الصراف رئيس فرع الطب في كلية الطب جامعة الموصل. المنصة لكم جناب الدكتورة ونحن نصير.
شكرا جزيلا دكتور عبد الرحمن، دائما كلماته تنطي بصمه واضحه للمؤتمرات اللي يحضرها ويقدمها. نفتخر انه خريج كليتنا ان شاء الله يكون بيتقدم اكثر واكثر. بسم الله الرحمن الرحيم. ان شاء الله نفتتح ورشه العمل اليوم. يسر كليه الطب جامعه الموصل فرع الطب ان ترحب بجميع الحضور اجمل ترحيب في الورشه العلميه الموسومه المستجدات في امراض القلب والايض. إن انعقاد هذه الورشة يأتي ضمن سعي كلية الطب الدائم إلى متابعة التطورات العلمية الحديثة والحرص على إثراء المعرفة الطبية لدى تدريسيها وطلبتها والأطباء العاملين في المؤسسات الصحية كافة. فالأمراض القلبية والاضطرابات الأيضية تعد من أهم التحديات الصحية على مستوى العالم، ولما لها من تأثير بالغ في صحة الأفراد وجودة حياتهم. الأمر الذي يجعل الاطلاع على آخر المستجدات في تشخيصها وعلاجها ضرورة ملحة لجميع الأطباء المتخصصين وغير المتخصصين. نلتقي اليوم بنخبة متميزة من الأساتذة والخبراء في هذا المجال لمناقشة محاور علمية دقيقة تهدف إلى تبادل الخبرات وتقديم الفائدة العلمية والعملية للحضور، كما أن هذه الندوة تمثل جسراً للتواصل العلمي بين الجامعات ومؤسسات الرعاية الصحية، وتفتح آفاقاً للتعاون في مجال البحوث الطبية والتطبيقات السريرية الحديثة. إننا نرحب بكم جميعاً أكاديميين وأطباء وباحثين وطلبة. نتمنى أن تكون هذه الندوة العلمية رافداً للمعرفة ومنبراً للحوار البناء ومناسبة لتعزيز روح التعاون خدمة للعلم والمجتمع. فأهلاً وسهلاً بكم، ونسأل الله تعالى أن يوفق الجميع لما فيه الخير والفائدة، وشكراً لحضوركم جميعاً.
الشكر موصول للدكتورة أروى الصلاف المحترمة على هذه الكلمة وعلى الإشادة بتواجدنا سعيد اليوم لأقود هذه الورشة الطيبة المباركة. سادتي الأكارم، الآن أدعو البروفيسور الأستاذ خالد نافع الخير لترأس الجلسة العلمية الأولى والتي ستحمل عنوان Updates in Heart Failure. نطلب منكم سادتي الأكارم حسن الإصغاء والاستماع.
Bismillahirrahmanirrahim. Welcome to the first scientific session. Today we have three distinguished speakers. We have three topics to be covered in this session about the updates in heart failure, understanding cardiac amyloidosis, new guidelines for management of cardiovascular disease and pregnancy. 15 minutes for each speaker, and the discussion will be at the end of the session. First of all, I will ask Assistant Dr. Arwa Mahmoud Saraf to present here to talk about updates in heart failure.
شكرا جزيلا دكتور خالد على التقديم. إذا نبدأ المحاضرة الأولى. الحقيقة هي 3 محاضرات كارديولوجي و3 محاضرات rather metabolic and renal. ففي المحاضرة الأولى إن شاء الله the updates in heart failure, focusing today on obesity to make it related to the metabolic diseases. These are the objectives of my lecture. I will not waste time you will listen to it. Let us know something about the problem of the heart failure worldwide. We need to know that up to 25% of patients with heart failure, they will die within 1 year of diagnosis. So it's very serious. And around 50% of them will die within 5 years of diagnosis. The decline in overall heart failure incidence from 2011 to 2014 was noticed with declining incidence of heart failure with reduced ejection fraction. But there is increasing incidence of the heart failure with a preserved ejection fraction, and this, as we will notice later, may be related to the obesity problem and the metabolic diseases, which is more leading to this type of heart failure. Regarding our Middle East Arab countries, the average age of affected individuals, they are usually less than 10 years younger than their correspondents in other society. And there is around 4 million patients having heart failure in this region of the world. I wanted to know the last definition of heart failure, which is the 2021, was called the universal definition of heart failure. As you notice here, the heart failure now is considered as a clinical syndrome rather than a single disease. And it is characterized by, first of all, symptoms, for example, dyspnea and fatigability, with or without signs, for example, elevated JVP, leg edema, and pulmonary crackles. And this usually caused by either structural or functional cardiac problem or both of them. And this is corroborated by elevated natriuretic peptides level and or objective evidence of cardiogenic pulmonary or systemic congestion. So within the definition, the natriuretic peptide levels also, now it is part of definition of the heart failure. Regarding the classification of the heart failure, also there are many updates, and usually it comes every few years, there's updating of the classification. The last classification, if we considering the stages of the heart failure, we have stage A, B, C, and D. Stage A, where there is risk factors, but there is no structural heart disease yet, and there is no signs and symptoms. The stage B, when there is already structural heart disease happens, but there is no signs or symptoms of the patients. For stage C, which is the most common type of the stages of heart failure that we notice in hospitals and also in our clinic, is because there is underlying structural or functional heart disease associated with signs and symptoms. So when the signs and symptoms of the heart failure appear, we are dealing with a heart failure with stage C. And then the advanced heart failure, which is stage D, here the patient, although he's in complete anti-failure therapy, he still complains of signs and symptoms, and usually they need more advanced and more difficult modes of medication and maybe even heart transplant or other modality of devices. Regarding classification of heart failure also can be classified in another way. That's to say we have 4 types of heart failure depending on the ejection fraction rather than on the signs and symptoms. This is the classification need to be done after echocardiography. First type is the heart failure with reduced ejection fraction when the ejection fraction is less than 40. The second one is when heart failure with mildly reduced ejection fraction when the ejection is between 41 to 49. The other one is heart failure with preserved ejection fraction, which is previously called as diastolic heart failure. Here the heart failure with ejection fraction more than 50%. And also we have another term that's heart failure with improved ejection fraction when it was below 30 and become more than 40, so it will be considered as improved type. Another type of classification, this is old one, all of us when we were medical students, we learn about this type of classification, which is the NIHA classification. This will depend mainly on the clinical severity of the disease. We have the NIHA class 1 with no symptoms, with a normal physical activity, only severe activity will cause symptoms, and graduate up to the NIHA class 4, where there is severe symptoms even at rest. Regarding diagnostic algorithm for heart failure in general and how to classify left ventricular ejection fraction according to what we say about classification. First of all, we need to assess the patient clinically by taking history, physical examination, and making basal ECG and laboratory test. Then, if we suspect the heart failure, we need to do one of them or both of them, the natriuretic peptides, which, as we say, it's part of definition now. And if it is elevated, we can do echocardiography to confirm and to read the ejection fraction. And also, we can start by both of them to do the natriuretic peptide and the transthoracic echo. Then, after we diagnose the heart failure, we need to know what's the underlying cause, because some causes are treatable, some are not. So if it's treatable, we can at least stop the progression or reverse the condition. And also, we need to evaluate any precipitating factors, especially فترة الإنفلونزا. Many patients they present with heart failure due to chest infection, for example. If we treat, at least you can convert the patient to the stable form of heart failure. Also, then to initiate the treatment and decide what treatment to give, and then to have serial assessment of the heart failure, because it may come from stage to other stage according to the ejection fraction progress. So what are the underlying causes of heart failure? As you notice, the first important risk factors here, the 4 risk factors in here, hypertension and obesity, which I put in red line because it can cause all of these risk factors, and also the prediabetes and diabetes itself, and also the atherosclerotic cardiovascular disease. These are the main risk factors. Presence of the obesity, it may increase the hypertension, it may increase the diabetes probability, and also lead to atherosclerotic process earlier than other patients. This can lead to 2 types of causes of heart failure, either ischemic cause, lead to with ischemia or with myocardial infarction followed by heart failure, or non-ischemic causes with a long list, as you notice here, including chemotherapy, cardiotoxic medication, rheumatological condition, endocrine, familial, genetic heart disease, heart rhythm like atrial fibrillation or tachyarrhythmia, also hypertension itself per se, infiltrative cardiac disease اللي راح يتكلم عليه إن شاء الله زميلنا الدكتور ضياء. like amyloidosis, other types of myocarditis, cardiomyopathy, stress cardiomyopathy, and some substance abuse like heroin. The initial evaluation of patients with heart failure, first of all, we need to take a good history and physical examination, including family history, including previous history, etc., and then to do laboratory test and ECG. All patients, they should have a basic test for sugar, for renal function, for liver function test, and for lipid profile, and for thyroid function test. Then 12-lead ECG should be done for all patients. This is recommended as a recommendation. And for patients presenting with heart failure, we try to find a specific cause by doing another more specific diagnostic test. The initial and serial evaluation, first of all, as we say, we use the biomarkers, the pro-BNP and the BNP, and the indications in front of you. Any patient with dyspnea may need to do these tests, and those patients at risk of heart failure as a screening for the heart failure, and those hospitalized to know the prognosis and to the response of the treatment, and those with chronic heart failure also to know the prognosis and the progress of the disease. Also, from the initial evaluation, we need to evaluate for cardiac imaging, especially the chest X-ray, thoracic echo, cardiac CT and MRI, and ischemic evaluation for those cases suspected to have ischemia by doing catheterization. Recommendation for patient at risk of heart failure and pre-heart failure. First of all, primary prevention is indicated, for example, treatment of blood pressure and initiation of GL2 inhibitors, especially for diabetic patients, and other optimal management of other cardiovascular disease or other disease. And for those patients with hem stage B, اللي قلنا عليهم structural heart disease but without symptoms, we need to prevent the syndrome progress by giving more specific medication like angiotensin converting enzyme inhibitor or the ARB and the beta blockers, and sometimes we need to put intracardiac devices for prevention of arrhythmias. For treatment of heart failure with reduced ejection fraction, stage C and D, we can say, those patients they will need special treatment with 4 very important drugs اللي هي الأرني, new medication اللي هي containing valsartan and sacubitril, and the beta blockers and the mineraloreceptor antagonist and the SGL2 inhibitors, and also diuretic can be used as needed. If the patient not respond, then we can go to further medication and make do the CRT or the using of nitrates, for example, and more progress to other device treatment. So the most important 4 types of medication here: the mineralocorticoid receptor antagonist, the ARNI, the SGL2 inhibitors, and the beta blockers. Additional medical therapies can be used sometimes if indicated, like ivabradine, versequat, digoxin, the PUVA, the omega-3, and the potassium binders in certain types of heart failure patients. I will now concentrate on my subjects, obesity and heart failure. We need to know that the prevalence of obesity is increasing about 3-fold since 1975 till now. We need to know that every 8 persons, 1 of them is obese. So it is really a very high percentage. And also we need to know that this obesity will increase the heart failure with result ejection fraction اللي حكينا عليه with diastolic heart failure by 3 folds. And it will increase the heart failure with reduced ejection fraction up to 2 folds. So we need to know that also every 1 of the 3 patients with heart failure with result ejection fraction are obese, and every 1 from 4 obese patients with heart failure with reduced ejection fraction is obese. The key points we need to know that obesity carry a high risk of cardiovascular disease, especially heart failure, and especially the heart failure with the preserved ejection fraction. Obesity problem, it have symptoms that may mimic heart failure because it causes tachypnea, fatigability, dyspnea. So sometimes the diagnosis of heart failure is challenging in those group of patients. Central adiposity and especially the visceral and epicardial fat, which you can see in the echo study, have 2 effects on the cardiac function, either by direct effect by causing pathogenesis of inflammation and hemodynamic overload, and indirectly because it is associated, as we say, with other metabolic disease like diabetes, sleep apnea, hypertension, and dyslipidemia. So obesity independently contributes to various cardiovascular alterations, including left ventricular hypertrophy, diastolic dysfunction, plasma volume expansion, and elevation of cardiac filling pressures, and also leading to the dyspnea and to the edema. This diagram will show us that obesity, when it starts, especially the central obesity, lead to many, as you say, hemodynamic changes, especially presence of the epicardial adipose tissue, and also increase in the glucose intolerance, hyperlipidemia, RAS activation, all of these will lead to the affection of the right and the left ventricle functions with more fluid overload on the right volume and on the left filling pressures. And this will lead progressively to heart failure symptoms and decreased exercise capacity. Also, there is an effect on the cardiac muscle itself. There is some toxic effect of this lipid called lipotoxicity. This can change many things inside the cell. I will not bother you with all of these details, but we need to know that cardiomyocyte itself is affected by this fat deposition. If I want to talk about obesity and heart failure prognosis, this is an issue of discussion for years. We learned that sometimes they will tell us that the obese patient who have heart failure, they live longer than thin patient with heart failure. And this theory really now is not accepted anymore, because there are some mistakes when they measure the obesity regarding body mass index. It is not the same as using the waist to hip ratio to check exactly for the central obesity. Previously, the relationship between the body mass index and mortality was U-shaped. That's to say, when the body mass index decreased, decrease the mortality. إلى أن يصل إلى body mass index reduction more will cause more advance to death. So it is a U-shape. Decrease, first of all, is beneficial. Then more decrease will be harmful. Characteristic of patients with heart failure and obesity. In heart failure, regardless of ejection fraction, patients with obesity are more likely to be women, and they are younger. فمعظم المرضى اللي عندهم diastolic dysfunction أو preserved ejection fraction and obese, they are female, and usually they are younger in age. They have usually medical history of hypertension, diabetes, and atrial fibrillation, and they are more likely to be symptomatic. That's why they are earlier treated than other groups of patients. Diagnostic consideration in subjects with heart failure. Really, diagnosis, as we say, is sometimes challenging because of the associated symptoms both for the obesity and for the heart failure. The characteristic early identification of dyspnea as a cardiogenic source will help a lot to diagnose that this is symptoms due to the obesity or to the overload in the venous overload. So cardiac filling pressures is the key answer if it is measured to know that this patient symptoms is due to the obesity or due to the associated diastolic dysfunction. Cardiac imaging also challenging because it's more difficult technically to do echo in obese patients. Also, sometimes when we take the measures of the left ventricle and left atrial volumes, we contribute that to the surface area, which is changeable in patients with obesity because it will be not correct, not true. So better to be height-based rather than surface area-based. Also, presence of epicardial and pericardial fat is important to be concentrated on. This will cause a lot of fibrosis, poor relaxation, etc., and this will also be seen by echocardiography. Treatment for obesity in heart failure, we need to treat obesity to ameliorate inflammation and to decrease insulin resistance. Weight loss is beneficial, and especially in patients with HFpEF, and also for patients with reduced ejection fraction, advised to lose from 5 to 10% of those obese patients will improve the prognosis of heart failure. Weight loss strategy, first, of course, exercise as much as the patient can tolerate, and pay attention here that body mass index is not only the matter, we also need to concentrate about the muscle mass. We don't want the patient to lose muscle mass, and this make him more debilitated and sick. And diet intervention also, this is important. By dieting, this will activate the AMP activated protein kinase, and this will lead to improvement of the cardiac function. The pharmacological treatment for obesity and heart failure, most of the drugs, as you notice here, اللي هي باللون البرتقالي, here all are harmful to the heart because it causes increased heart rate. Some of them affect the valves itself. The only safe old classical drug who will only studied can be used. It can, with dieting, can make patients lose up to 8 kilograms sometimes. And this one only because it is fully tolerated because of steatorrhea and urgency, but it is good and it can improve cardiometabolic disease. The new medications اللي هي حاليا تستخدم للهارت failure and also it is good for the obesity is the SGLT2 inhibitors. This can reduce weight up to 4 kilograms sometimes, and it is first step treatment for diabetic patients and also now added to the main cornerstone treatment for heart failure. The other important drugs, I finish already. Glucagon-like peptide 1 receptor agonist اللي هي GLP-1. This will be more beneficial really in the heart failure with preserved ejection fraction because it have improving metabolic parameters, endothelial functions, improving relaxation and decrease fibrosis of the heart, and also decrease oxidative stress and inflammatory pathways. Also, it can be used alone to lose weight even without diabetes and without heart failure. And also, it is used, of course, in type 2 diabetes, and it will be good to reduce the cardiac-related death. اللي غير اتكلم عنه ذا نيو دراج الحقيقه اللي كنا بالمؤتمر في ايجيبت هو التيريزيباتايد اللي هو نيو دراج الحقيقه have dual action. It is a GLP-1 glucagon like peptide 1 and also it is a glucose dependent insulinotropic polypeptides. So this drug is a dual incretin mimetic, meaning it acts like two natural hormones that help to control blood pressure, blood sugar, and also decrease appetite and improve weight loss. It is used especially for patients with HFpEF, but not yet for heart failure with reduced ejection fraction. ايضا النيو ثينجز البحوث الاخيره اللي هي النون ستيرويدال مينرال كورتيكوستيرويد اجونست اللي هي الانتاجونست اللي هي ريسنتلي ديليفرد اللي هي الفاينيرونول اللي studied very well for patients with renal failure and it is improved. It will improve prognosis in chronic kidney disease, but even now new studies that particularly appealing in obesity-related heart failure with preserved ejection fraction, well, adipocyte aldosterone is increased in those patients, so this drug is, we think that it will be beneficial in such cases. The treatment by bariatric surgery, really, there is no enough study for that, and still it carry a very high risk factors because there is an 8-fold high risk of intraoperative cardiovascular death in such patients, and even a 3-fold higher risk in hospital mortality after the operation. So it is not accepted to be done. So in conclusion, obesity is an important cause for heart failure and it will also affect prognosis. Lifestyle modification and regarding exercise and diet is very important, and the new GLP-1 RAS and GLP-1 dual treatment here, new promising drugs for treating both diabetes, heart failure and obesity. And thank you very much.
Discussion. Thank you, Dr. for this nice presentation, updating the classification of heart failure and more detail about the obesity. The second speaker, Sister Jibril, will present his talk about understanding cardiac amyloidosis. I give you additional 5 minutes.
Thank you very much. Thank you, Mr. Chairman. Thank you, Mr. Chairman. Thank you, Mr. Dean and Dean Assistant and my colleague for your attendance. Thank you very much. I will talk about amyloidosis. I think all the witnesses think that amyloidosis is a very rare disease. لكن الواقع يعكس أن amyloidosis is not a rare disease in our locality, خاصة في محافظة الموصل. It seems to be not a rare disease. Over the last 3 years, we collect about 45 cases. Most of the cases are from the south of Mosul, القيام والشرقات همام الحديد, and غرب الموصل أيضا هو في البحاج. It needs to be considered that this is not a rare disease. Initially, amyloid was used by Professor Rodolphe Vicro in 1854, and the term amyloid was applied due to the color after staining of the tissue by a crude iodine stain. 5 years later on, they discovered that this material seemed to be protein, and the discovery was by Dr. Frederick and Coquille after 5 years. And the term amyloid is applied because the word comes from a Latin word, amylin, or amylon from Greek, which means cellulose or starch. But the term amyloidosis is applied to the protein that occur as a misfolding protein that result in formations of fibrils